Okay, chapter 20. There's a part one and part two to this. Really, part one, we're just going to discuss oxygen therapy and some things to think about. These are all kind of things that you should be getting, you should know, or you're getting taught through things, like health assessment, other stuff you learn. So hopefully, this is not complete news. But so, oxygen therapy, oxygen concentration. So, room air is about 21%. That's what atmosphere is on Earth, 21% oxygen. We're talking about indications for oxygen therapy, complications again, low oxygen pulsat, dyspnea, things like that, cardiac conditions, cardiac angina, heart attacks are all kind of indications for oxygen therapy. Some of the devices we talk about the flow meter, nasal cannula, Ventimask or Venturi is kind of how it's spelled, but Ventimask, non-rebreather, those kind of things. So oxygen flow meter, you've probably seen these before. They go up to 15 liters per minute. You just crank them and they go up. Oxygen on the walls in most every hospital, or oxygen tanks, that sort of stuff, similar. Most normal way we do this is a nasal cannula. Nasal cannula should never really go above 6 liters per minute, really 5, but 6 liters per minute. If you have to go above that to get someone's oxygen saturation, we talk about a high flow nasal cannula. Now, high flow nasal cannulas are newer in the last few years, but last 10 or so years, maybe 5 or 10 years. They are in the same shape as a nasal cannula. The only difference is their tubing is rated for higher flow through the nasal cannula. And so those can be cranked up higher than 6 liters. And they're almost used like a kind of like a mini CPAP kind of deal. They're interesting, but they're they kind of force the air in. So high flow nasal cannulas are very interesting. Ventimask, again, Venturi is kind of how it's spelled, but most people just call it a Ventimask. It's a mask that actually usually comes with attachments or a way to titrate the percentage of oxygen. So it kind of goes up from like 24%, which is slightly more right than atmospheric, up to 60%, and that can supplement O2 for someone that needs more than an oxygen through a nasal cannula and needs something to cover their whole mouth because maybe their mouth breathing and we need higher amounts of oxygen. So non-rebreather is the top dog for 100% O2. Like we're giving 100% O2, 15-liter max output on everything. They breathe back in. It's supposed to just give them it's basically, it doesn't waste any oxygen. That's what it's called, a non-rebreather, because we're not wasting the oxygen out and rebreathing. We are full on. So this is what we need in case of like acute emergencies. Usually non-rebreather is contraindicated until you get to an O2 sat reading somewhere below 75 to 74%. If we're below 74%, it's time for a non-rebreather. But we want to try other methods before that percentage. Also, trach collar works very much similar to nasal cannula. It's just wider, so somewhat like a Ventimask, but without the control of percentage. This will usually be controlled through other machines. And then on the left here, you have incentive spirometer. Again, you can kind of set someone's lung volume to see how well they can do this. And this one always kind of throws people because they feel like it's something that should be it's more for expiration, so deep breaths and expiration. Most people think you suck, but you actually blow into these. And then it's kind of same thing with the flutter valve. The flutter valve device here is basically trying to help cough and get rid of secretions, force that kind of deep breathing. This is a nebulizer. You can attach a medicine here, oral steroids, and try to kind of, again, bronchodilate using medication through this. Pursed lip breathing is something that's kind of part of therapy, but pursed lip breathing is breathing technique that involves inhaling through the nose and exhaling through pursed lips. So like almost making a whistling sound. This is really good for working out and that sort of thing. It's good for runners, but this is an effective way to talk about someone breathing when they're short of breath and trying to, again, or improve physical activity, that sort of stuff. This is a kind of And what you would tell someone to do is kind of be sitting, relax their neck and shoulders, inhale slowly through the nose, pucker their lips if they're going to whistle, and then blow out like they're blowing a candle. And so, and it's not a, not forcing, not exhale should be a passive process. So it's still a passive. They're not forcing air out when they do pursed breathing, but this is an effective way of breathing techniques. Some of this stuff, postural drainage, talks about positioning. Can be helpful to move secretions like mucus and other things around the lungs. This is not need to know necessarily, but interesting. Another thing that's interesting too that you may not do, but you'll probably see is some percussion. Percussion is making a cup with your hand and basically kind of beating on someone's chest, but basically it's there to try to help break up secretions inside the lungs. Is a goal of percussion. And then you can tell someone to purse lip breathing and kind of have them feel it basically. Intubation, that is taking an ET tube, endotracheal tube, and passing it into the mouth, through the pharynx, larynx, and into the trachea, and then blowing a balloon up to keep it positioned in the trachea. For comatose patients, you need a laryngoscope, which is the metal device here to pry, push back the tongue and be able to have access to the throat. This is in case of a severe respiratory emergencies when they're not breathing on their own anymore, that sort of stuff. Cardiac arrest. Tracheotomy. So for a trach is an incision right in the neck, bypassing the upper airway and going straight to the trachea through the throat. It has to be a cut through the cartilage, and then the tube gets placed in there, and then a balloon is inflated to keep it in place. If this is for an upper airway obstruction, someone that's on long-term mechanical ventilation and we can't get them off of it to breathe on their own, they could be trached, and that tends to kind of give them the ability to breathe on their own again, but it'll be probably permanent. Other disease processes. Some other machinery we use commonly, we have CPAP and a BiPAP. CPAP is pretty much exclusively used, almost exclusively in obstructive sleep apnea. It gives positive pressure cycles to kind of help that person breathe and keep them from stop breathing, because apnea is cessation of breathing. So sleep apnea is a nocturnal cessation of breathing, and this is trying to kind of force the air movement and keep them breathing regular. They're breathing regular while they sleep. And a BiPAP is a bi-level positive, where CPAP is like continuous positive airway pressure. Bi-level positive airway pressure is basically independent control of inspiration, expiration, and it can be set. Usually respiratory therapy messes with these, but doctors do make the final call on what the settings are. For patients that are severe COPD and sometimes severe sleep apnea, but mostly severe COPD, the BiPAP is the better option because of its ability to control inspiration, expiration, and it's a greater force than a CPAP. And that's why they use BiPAP at night for patients with extreme COPD, other respiratory conditions. In CPAP, pretty much mostly used in this obstructive sleep apnea. You can do for other respiratory conditions. Again, independent control, BiPAP, much more for severe cases. And then obstructive sleep apnea, just to kind of see it, is basically the tongue is the soft. Basically, what happens with sleep apnea is it's linked to snoring and obesity and weight gain, but it mainly has a lot to do with the relaxation of the tongue towards the back of the throat and then blocking the airway. Then they stop breathing. So that's what we're trying to correct, is force the air through to keep that open. And then other risk factors, AFib, high blood pressure, congestive heart failure, all potential for needing CPAP intervention. So part 2 of this talks all about the COPDs. So chronic COPD, again, stands for chronic obstructive pulmonary disease. There's mainly 2 culprits. There's chronic bronchitis and emphysema. We're going to talk about asthma in this too, because asthma technically is in the family of COPD. COPD just stands for chronic obstructive pulmonary diseases, and asthma is an obstructive pulmonary disease. People don't think of it as COPD, but it is part of the family technically. But mostly when you say COPD in a healthcare setting, you're probably talking about either chronic bronchitis or emphysema. So bronchitis is much more linked to increased mucus production and inflammation in the large airways. Emphysema is more issues with impaired gas exchange because the alveoli walls have been destroyed or balloon out and are not lose their elasticity, and then therefore gas exchange doesn't take place. So much more associated with gas exchange issues and issues exhaling. With emphysema, bronchitis is much more productive cough, mucus, frequent pneumonias, that sort of thing. So risk factors for COPD, the biggest one is always going to be cigarette smoking. It does not mean that someone develops COPD. They don't necessarily have to be a smoker. There could be other factors. There is some small genetic links, but if it's not cigarette smoking, air pollution, and occupational hazards, coal miners, people that work in factories, that sort of thing, have potential to develop COPD. People that had a childhood asthma or asthma most of their life, there could develop other forms of COPD in the emphysema family or bronchitis family. So chronic bronchitis, a big portion of this content for this part 2 of chapter 20 is really just trying to get you, make sure you know the difference between chronic bronchitis and emphysema. Know the difference between COPD. So summarize it right there. That's the rest of these slides are talking about. So chronic bronchitis is much more associated with swelling, inflammation of the large airways, the bronchioles, and therefore copious, large amounts of mucus production. So huge productive cough, bronchial tubes are inflamed, engorged. Emphysema is much more known for alveoli collapsing like this or blowing up and air being trapped. So emphysema is known with air trapping and poor gas exchange. And a lot of times their alveoli is destroyed, so they have poor gas exchange. The alveoli they inflate and air gets trapped and they have to work really hard to exhale. Exhale should be a passive process. People with chronic emphysema usually if they have a cough, it's dry and they have a hard time exhaling. They usually use a lot of effort. So there's a bunch of comparisons over the next couple slides, but something that's been a theme for a long time that people talk about the difference between chronic bronchitis and emphysema is chronic bronchitis is blue bloater, emphysema is pink puffer. So what they're kind of trying to get is that blue bloater is the flow through the airway is a problem. The large airways, the bronchi are the problem, and the bronchioles. So a huge amount of sputum and cough and mucus increase. They're going to be hypoxic. Usually definitely have hypercapnia, so elevated CO2. And because of their hypoxia, they're going to be much more likely to be blue tinged, cyanotic most of the time. High incidence. This is high linked to smokers. They're going to have clubbing of their fingernails. They're much more likely to have heart failure or cardiac, what they call core pulmonary, cardiac issues related to their heart having to work hard to pump blood through their lungs that's full of mucus. So yeah, right-sided heart failure, pulmonary edema, they're going to have pulmonary edema, generalized edema. So that's what they call the blue bloaters. They're going to be hypoxic, edema, heart failure, cyanotic, dusky, large cough with copious mucus. Emphysema is the pink puffers. They're going to definitely have hypercapnia and CO2 retention. They usually don't have a lot of cyanosis, and they are really always purslet breathing and dyspneic a lot of times because they're always working hard to try and get their air out of their lungs. They have this orthopenic or this barrel chest, this chest that's 1-to-1 diameter to height, where ours is usually 1-to-2 diameter to height. So their chest enlarges because they're working so hard and air's trapping, and they kind of just always feel like they can't get the air out. They're going to be very tired, usually skinny, not overweight or obese because they're always working so hard, using their accessory muscles often. So thin, anxious, use of accessory muscles, barrel chest, pink, not cyanotic, purslet breathing, that sort of stuff. And then the rest of these just kind of summarize them again and again. Next few slides. So again, chronic bronchitis, productive cough, overweight and cyanotic, edema, probably going to hear rhonchi and wheezing, where emphysema is usually older, thin, severe dyspnea, severe barrel chest with hyperinflation, the destruction of the airway space. So again, more slides about it. Think chronic bronchitis, blue puffer or blue bloater, edema, fluid shifts, mucus production, inflammation of the large airways, where emphysema, pink puffers is smaller bronchi, hyperinflated alveoli, air trapping, barrel chest, that sort of stuff. And so bronchitis versus emphysema, you can kind of see like some of the fluid buildup and the large heart you would see with the blue bloater, and this is a bigger person, and you can see the chest is very large over here. You don't see all that consolidation necessarily, but this is a emphysema, big barrel chest. And a lot of times with this too, they'll do tripod positioning, which means they'll kind of sit up and they'll purse lip breathe like this often. They're orthopedic. They can't lay down at all really to breathe. It really is tough on them. They work really hard to exhale, which should be passive. So etiology of COPD, again, smoking, history of allergies, history of asthma, all, and then again, air pollution, chemical exposure, all more prone to it. There is infectious components. People having viral or bacterial pneumonias frequently could lead to COPD. This is done by exacerbation. Sorry. So exacerbation is the term they usually use with COPD. If we have COPD somewhat under control with medications and that sort of thing, when people have flare ups and they get really sick and they're struggling with, they have to go to the hospital because their O2 sat's low and they're dyspneic and all the things. That's an exacerbation of their chronic COPD, and typically it's going to be either infectious or again non-infectious allergies, that sort of stuff. Treatment, you want to know this kind of line here, or this kind of the therapy. Again, for those person, depending on what they have going on, biggest thing we can do is get them to stop smoking if that's the root cause. On like right in the middle ground too is that we can make sure they have their flu vaccine to prevent them getting the virus, therefore getting viral pneumonia more likely, or depending on their age, pneumococcal pneumonia vaccine as well. And then the bottom of this chart just talks about their pulmonary function tests, their, how much air they're moving, that sort of stuff. Typically, the methodology for treatment is start with a SABA, a short-acting beta analergic. So SABAs are like albuterol, like a rescue inhaler, that sort of stuff. And then we could add long-acting LABA, long-acting bronchodilators. So salmeterol, formoterol, long acting for like maintenance, along with the short acting, the SABA. Also could throw in on the third tier, you would throw in next kind of inhaled steroids, glucocorticoids like fluticasone, which is Flovent, Pulmicort, those kind of things. Those are for like long-term chronic steroid. Long-term O2 therapy is at the kind of tail end as the symptoms worsen and we get to kind of the end stage of COPD. They chronically can't keep their oxygen up on room air and they'd have to have O2 therapy. The goal for this too is we could do pulmonary rehab, which is about help with exercise, improvement in quality of life and ADLs, and try to reduce hospitalizations and exacerbations of COPD. That's kind of the goal. And then this is some of the treatments. Again, assessments, chest X-ray, gold standard, ABG as well, because we usually have some hypercapnia going on. Mess around with medications or oral steroids. They could add IV corticosteroids or an IV bronchodilator. Aminophyllene is one, but that's in like acute exacerbation stage. So asthma. Asthma is a disease that affects the lungs. Basically, with asthma, you want to think it's a chronic airway disease. It's chronic inflammation, hyper responsiveness to allergens, dander, dust, and it's going to cause bronchial constriction, kind of big three. So inflammation leads to bronchial constriction, leads to mucus production. So for asthma patients, it's avoiding what the trigger is. Some people have exercise induced asthma, that sort of stuff. So a lot of with asthma is avoiding triggers. So for asthma, usually it's someone that already has allergies or hypersensitivity to other things. Typically, incidence is higher in males, and usually onsets earlier in childhood. And sometimes people can grow out of this as they grow because their airways get bigger. But with asthma, there's a familial link to it. They're going to have increased mucus production, be short of breath, and the trademark kind of sound for them is that expiratory wheeze. They could have wheezes on inspiration, but commonly it's expiratory wheezes. As air rushes out of tightened airways. They could have CO2 retention. The emergency is the status asthmaticus. So that's a need to know status asthmaticus. Status asthmaticus is a life-threatening condition where basically their rescue haler that they're normally do to try and alleviate symptoms is just not working. And so the asthma is just sustaining the short-acting, the SABA, the albuterol, usually the short-acting inhaler, and that would be time to call the doctor. There's definitely possibilities of pneumonias, airway obstruction from the mucus, atelectasis, that sort of stuff. And this is kind of just giving people warning signs of an asthma attack versus symptoms. Overall, I think you could summarize asthma like right here is the need to know these big three as far as the pathophysiology goes. Whatever the trigger is, again, pet dander, allergies, bad perfume, whatever triggers, exercise. It's usually, again, hypersensitivity things, cigarette smoke, whatever, secondhand smoke. It's going to cause huge amounts of airway inflammation. And these big three right here is the big thing to take home is hypersecretion of mucus, airway muscle constriction. So bronchioles constrict down, get tighter, and then the membranes of the bronchioles get tighter. So these are kind of the big three. So think inflammation of the airways, bronchioles constrict, increased mucus production. And again, treatment similar to COPD, but typically the first line of step is always a SABA, the albuterol inhaler, stuff like that. And then they can go to steroids or LABAs, Flovent, Pulmicort. The one thing I think you need to know about this is patient teaching just regarding proper administration of meds with an inhaler. You have to remember that they need to typically, especially for rescue inhaler, you need to wait at least 60 seconds in between puffs, and it's usually 2 puffs as needed, PRN, Q 4 to 6 hours, depending on the frequency. And sometimes they can also use a spacer, which adds like a chamber to the end of the inhaler, and a spacer will allow them to, instead of squeezing it directly into their mouth, directly into the chamber, and that'll give them the ability to breathe through that chamber that's attached to the inhaler. And those are pretty helpful too for making sure you get a full dose. And they can also, there's things called a peak flow meter. This for asthma patients is kind of an interesting need to know, but the peak flow interesting, nice to know. Peak flow is just a device that allows them to check their exhalation pressure and that sort of stuff. And that would tell an asthma patient, like if they're spotting no early warning signs to them having an exacerbation or an asthma attack. This is an asthma action plan. This talks about things to do at home, that sort of stuff. So a lot of it goes with teaching. But yeah, so that's the part 2 of chapter 20, and that wraps up kind of everything with unit 2. So we're done with that, thankfully. And so unit 2 is dedicated to diabetes and all the respiratory stuff. So thanks for your time watching. Hope you guys have a great rest of your day. Appreciate you.